Good morning. Today we'll be talking about children with cancer. This month, the month of September, is the Child Cancer Awareness Month. It is only right that we spend some time talking about this very important issue. I'd like to thank both Dr. Akinsete and Dr. Nwobbi for joining us. If I may start off with you, Dr. Akinsete, can you tell us about childhood cancers? How common are they globally and in Nigeria?
Yeah, thank you, Dr. Ajay, for having me on the show. So childhood cancers are pretty much common globally. And because of enhanced diagnostic capacity, we are seeing more of such kids in our own practice here in Nigeria. So globally, it's estimated that there are about 400,000 new diagnoses every year. And we've got 60 to 70% of those diagnoses in low to middle income countries like Nigeria. So in our practice here in Lagos, we see between 60 to 80 new diagnoses every year. And consistently over the last 3 to 4 years, we've seen an increased number of children coming down with childhood cancers. With regards to survival or, a positive treatment course, we haven't had as much success in this part of the world. So when you look at the literature from people in more resource-endowed settings, 80 to 90% of kids will survive. In our setting here, in the best of our places, 50, 60% survival is what we'll get, while generally across the nation, about 10, 20% survival is what you would have. So it's pretty much common. Unfortunately, because our emphasis is usually on the adult type cancers, breast, colon, cervix, lungs, we don't tend to get as much awareness and support for pediatric cancers in Nigeria.
Wow, I think that's actually really a shame, because if there's such a high survival rate globally, then it's something that really we should be pushing more for. So I'm happy we're doing this episode today, focused on those kind of childhood cancers. So can you tell us the kind of cancers that are common in childhood? And how can parents who are now listening to this, or grandparents as it were, or community leaders who are now listening to this program, how can they spot them?
So thank you very much. So the commonest cancers that we see in our practice are the blood cancers. They are called leukemias. There are two types of leukemias. One, the commonest one is the acute lymphoid leukemia, and the other type is the acute myeloid leukemia. The basic thing is that if a child is suddenly needing blood or is having fevers that don't seem to go away, has a fever on Monday, is treated Tuesday, Wednesday, fever recurs on Thursday, is treated Friday, Saturday, Sunday, fever comes in, we start seeing spots on the lips, spots on the nostrils, the child is having some bleeds from the nose or has a protuberant abdomen. These may be signs of leukemias. And if we've had to go to the same hospital 3, 4, 5 times in a space of 2, 3 months, and the child who was previously well is now needing blood, maybe that's the time to actually go higher and go to a teaching hospital and get some assistance. Then we have another one called Wilms tumor. Those are cancers of the kidney. It's quite common. That one really doesn't give any sign. The kids are fine until maybe they have a scan, and the scan will reveal that they've got cancers in their kidney. Then we have retinoblastoma. That's the cancer of the eye. So anytime you shine a torch, so power supply gets cut off, and the eye of the child is just, shining in the darkness, like the eye of a cat. That's a danger sign. We'll ask you to please rush to the hospital, because that's a common sign of retinoblastoma. Or if they shine a torch into the eye of the child and it doesn't shine the red spot back. So that's something to worry about, and we'll ask you to come to the hospital. Any swelling on the body, on the neck, on the arms, on the legs, any swelling whatsoever, we shouldn't ask people to cut it open and maybe it's an abscess. Once there is a swelling, I would kindly ask parents to take those kids and see a pediatrician who will decide if that swelling is something that we need to do some other testing for. So those are the common cancers that we have in this environment. There's some other ones like brain cancer. So ever since we had the Adeseye Cancer Center in LUTH, we're getting to see more children with brain tumors. And some of the signs are things like headache, recurrent headache, visual blurring, double vision. The child runs into objects while in the house. Early morning vomiting. Those are signs of brain tumors. I would ask that the parents should urgently come to the hospital so that we can institute care. Thank you.
Wow, thank you. That's quite a list. But you know, there are some people who are probably listening to this program and they're shocked. They're saying, you know what? How come? But these children have just been born. How do they come down with something as terrible as cancer? What causes it? Were they born with it? Did it just arise? Is there something that people did to cause it? You know, can you give us some sort of idea to the etiology, how it came about, and, you know, to sort of calm the nerves of people as to what is going on?
Okay, thank you, man. So the truth of the matter is that cancers are not hereditary in the loose use of that word. So you find that parents come in and you tell them that, oh, this 6-month-old has got a cancer, and the mom is distraught. Is it something I ate? Is it something I did? The dad is distraught. Pediatric cancers don't follow that trend. And so prevention is really the strong point in pediatric cancers, as you would find in adult type cancers. However, early diagnosis will mitigate a lot of the things that you find in pediatric cancers. Now, there are certain cancers that are familial. We would use the word familial. And in these ones, there are genetic predispositions. So I've had the opportunity of treating an adolescent whose mom had a cancer, whose uncle had a cancer, whose grandpa had a cancer. Now, that's a familial predisposition. You will find that in 1 out of 20 cases of pediatric cancers. However, the baseline thing for most of the cancers as we see them now, there's a genetic predisposition. There is some defect in the genes somewhat. And that may have occurred during the period of while the baby was growing up as fetus and all of that. And then there's an environmental factor which hits again on the same gene and predisposes the individual to a cancer. But that's in a very small percentage of cancers. In most of the other ones, there really is nothing genetic you can point to. These kids just come down with the cancers and we have to treat them for it. So things like ionizing radiation, if the mother is pregnant, have been implicated. Some types of medications.
Sorry, can you explain that? Ionizing radiation when mother is pregnant?
Okay, so if a mother is pregnant, we usually do not want them to be doing x-rays, chest x-rays, x-rays of the abdomen and all of that, because there's a potential that those rays, they are radioactive material, may damage certain growing cells in the unborn child. So we try to move parents of pregnant women away from x-rays or CT scans, which may predispose their fetuses to coming down with cancers in later life. So that's what I meant by ionizing radiation.
Okay, thank you. Please carry on.
Okay, so that's one way. I mean, that's another pathway by which cancers may occur. But by and large, the large percentage of kids who come down with cancers, we can't pin it to what they ate or what they did not eat, to things like what the parents did or what the parents didn't do. All of those things have little or no bearing on pediatric cancers generally from an etiologic standpoint.
Wow, thank you so much. I think that's really quite comprehensive. But I think one of the things that you did say that was, for me, very encouraging was the fact that a lot of people, a lot of children, particularly abroad, do very well, 80% survival. So what can we do to improve our own survival rates here in Nigeria from the low rates of 10 to 50% up to that 80% that we would like to see?
Oh, so thank you. So basically, what we found, so I'll just give an illustration to explain what we found. So in 2012, we published a paper in LUTH where we looked at Wilms tumor, that's the cancers of the kidney, and the survival rates were about 20%. When 5 years after, when you're treated a cohort, 2 out of 10 survived. So we then looked back and looked at why did these kids not do well in our environment, considering that Wilms tumor was a low-hanging fruit. So we discovered that each one of us made children with cancers were working in silos. So the pediatric oncologist was working without talking to the surgeon, without talking to the radiotherapist, without talking to the pathologist. And we decided to start a multidisciplinary team meeting called an MDT, that every child who comes into LUTH, all of the specialists will sit down and plan the care of the child. So we started that in 2015, 2016. And in 2022, we looked at our data over the last 5 years of doing the MDT and 5 years after we are treated. And we found that just by us talking before we started treatment and agreeing on the dates for surgery, dates for chemo, dates for radiation, we had moved our survival rate from 20% to 78%.
That's fantastic.
So that alone tells us that sometimes it's not just about throwing money at the problem. If you introspect and look at your processes, you may be able to improve outcome. And that's what we now do. That our parents and patients, they don't have the wherewithal for us to be throwing them from one specialty to the other. So the doctors are talking to each other, and we say, XY has come in today first. XY is supposed to have surgery on the 16th of October. Kindly ensure that that date doesn't move. XY is to have radiation on the 30th of October. Parents are aware of the cost implication will be, they will start trying to source for funds. And that has worked. The other bit is that we've also tried to form a local network where if it's not available within our own hospital, there may be somebody who is having a research capacity to run some of these samples for us at subsidized rates. And so we reach out. That has also moved up. So in 2015, if we had 10 children with leukemia coming, 9 of them will die. In 2024, as we speak in Lagos now, if 10 children come with leukemia, 6 will survive. So
that's fantastic. So
the limitation I would like to point out that parents pay out of pocket. And by the time they are halfway through the course of treatment, they are fatigued already financially. And that's where Dr. Nwobbi and several other support groups have helped us to keep the survival where we have it now. Because if we take away Dr. Nwobbi and all the other groups, our survival will crash back to 1 in 10. So the critical element is that part of why I said we need better awareness is that breast cancer, cervical cancers, prostate cancers get some support from the Cancer Health Fund from the Federal Ministry of Health. Currently, children don't get access to that fund. There's been a lot of advocacy, there's been a lot of presentation, and we do hope that
we need that to happen.
Yes, we'll put kids on that platform, because the truth of the matter is that pediatric cancers actually give you the best outcomes, better outcomes than adults.
Yes. Thank you. We will push for that. Thank you very much. Oh, Dr. Nwobbi, it's so lovely to have you here on the program with your wonderful foundation. Can you tell us about your foundation, why you started it, and the kind of care and support you give?
Thank you so much, Dr. Ajayi. We're Children Living with Cancer Foundation.
We were founded in 2003. That's we are 21 years this year. So we've been there, for a while. And basically, it was founded because at the time, there were no other charities in Nigeria supporting childhood cancers. We had quite a few for breast cancer and other adult cancers, and then nothing happening for the children. So we came on board because we needed to have something for the children. And since then, I must say that just like Dr. Akinsete have said, we've worked hand in hand with LUTH, to try to get as many of the children the things they need. One of the things that is actually helping us is, that parental support. Every parent that is there is like a family, because when you get there, it's not a day's job. You stay there for a long time, you form friends and families, and it's been quite an uphill task, but then we've done quite a bit.
No, and I want to appreciate you on behalf of all the families that have you supported, and also to join Dr. Akinsete in saying thank you. Just in case, I mean, we have some people who are touched by this and who want to support your foundation. Do you have a number that we could give them that they could reach out to you on?
Yes, 08033156908. That's
Please
the number
repeat.
two.
Please repeat.
08033156908.
Okay, thank you. And we had one of the survivors with us, don't we now?
Yes, we have. She's 12 years old. She had osteosarcoma. She came all the way from her.
Fantastic. Please, can we hear? I believe we have a parent and a child on today. Can you tell us a bit about how you found out your child had cancer, or the child, if you can speak to yourself, what happened, and let us know how it went.
Yeah, just a day that she came back from school and told me that her leg, she's having a painful leg. So I said, okay, I have to take her to the hospital to know why that leg is paining her and swelling up at the same time. So that was when they referred us to National Hospital, when we did the MRI test to know what was happening. And that's where we discovered it was osteosarcoma. And from there, we take it up and we are referred to LUTH to see what they can do about it. This 1 year treatment plan that we have been into, and to God be the glory today that we have finished our treatment and we have come to the end of it. And at the same time, thanking the founder of Children Living with Cancer Foundation, that have been of great help and assistance to see that we come to the end of this journey. It was not an easy one at all.
Thank God. Can we hear from her directly to tell us how she feels?
Yeah, you can hear from her. It's a girl of 12 years old.
Yes. Hi. So how do you feel? Now you've completed treatment. Come closer.
I'm very happy that.
No, I want to hear from her. How is she? How does she feel?
That you have completed your treatment.
I feel great. Free for and chemotherapy.
And has it affected school, or you've been able to go back to school?
Oh, yes.
That affected my academics seriously.
Okay. But you're going to be able to catch up?
You'll be able to catch up.
Yes, I will.
Okay, that's wonderful. So we're very happy to see you as a child survivor. We're happy to see Daddy as well. And we thank God for your life.
Thank you, Doctor. My pleasure.
Okay, so I don't think we have much time left. Dr. Nwobbi, do you have any last words for our listeners?
It's just to be more diligent for people to know that children too can have cancer, because even up till now, many people believe that it's an adult, ailment and not affect children. For them to know, be more aware, and then as Dr. Akinsete said, whatever it is that you're not certain of, take the child to a healthcare provider who would assess and tell you the next thing to do. Thank you.
Thank you. Dr. Akinsete, any last words?
Yes. So it's just to encourage parents that when they are not satisfied with the care they are getting, they should seek a second opinion. It's valid right. That's all.
Okay. Thank you. Thank you very much.
Thank you for watching. Please like, share, and subscribe for new video updates.